Dr. Morice will be presenting to you today on the lab's role in health equity, lessons learned through the COVID-19 pandemic. Dr. Morice is the chair of the Department of Laboratory Medicine and Pathology at Mayo Clinic here in Rochester, Minnesota, and the president of Mayo Clinic Laboratories. Dr. Morice is a consultant in the Division of Hematopathology and served as chair of that division from 2009 to 2015. He joined the staff at Mayo in 2000 and holds the academic rank of Professor of Laboratory Medicine and Pathology in the Mayo Clinic College of Medicine and Sciences. Dr. Morice is an expert in diagnostic hematopathology, flow cytometry, and T and NK cell biology, among other topics. He's a sought-after national and international lecturer and visiting professor, and has published more than 160 peer-reviewed articles, book chapters, and abstracts. In early 2020, Mayo Clinic developed one of the very first in the country tests for SARS-CoV-2. Based upon our early development of a test, Dr. Morice was invited to the White House advisory panel as it was forming to understand how to mount a national response to the COVID-19 pandemic. Mayo Clinic Laboratories was one of the very first reference laboratories in the country to get access to testing as part of the national response to COVID-19. From there, Dr. Morice went on to serve in numerous national and international groups, such as the World Economic Forum, to address how to get COVID-19 testing in the hands of people across the globe, and specifically addressing feasible and equitable ways to create access to COVID-19 testing during this unprecedented pandemic. And I know the lessons learned from that are going to be valuable to us all today. So without further ado, I will turn it over to Dr. Morice.
Thanks for that very kind introduction, Dr. Karen. All right, well, it's a real pleasure to join you here this morning. It's a big topic. First of all, the introduction always makes me a bit nervous. I set the expectations pretty high, but it really has been a fascinating journey over the last couple of years, and I'll try and just share that journey with you. And as I do, kind of what some of the challenges that this has really, the whole pandemic has revealed. Of course, the pandemic is still with us, and in particular, what some things it's taught us about equity in healthcare and healthcare delivery and healthcare access. There is the title as a presentation, as Dr. Karen shared with you already. I really have no disclosures. I have one advisory commitment I just made, but other than that, I really have nothing to disclose that's going to bias me or has biased me throughout this journey with COVID or as I talk today. So here's a timeline. It was hard to know how much of this to include, but I think it is interesting. We've been living with COVID now for over 2 years. And sometimes we lose track of just what that journey has been, or you need to be reminded, at least I do. So if you think back, I mean, so in December of 2019, was when we first started to hear stories about an unknown pathogen causing respiratory illness in Wuhan, China. It really didn't, and interestingly, I had been in China just in November and in Chengdu, so further west than Wuhan, which I've also been to, but it caught our attention. But it was like we knew that if you had traveled to China, any of you knew that we still had to go through temperature sensors and things because of SARS-1. Now, as it's called, at that time just SARS, and that really never impacted the world outside of China. So I don't know if a lot of us were really at that point. Certainly, I don't think there was a level of concern proportionate to what has been COVID. In January, there was, of course, the virus is identified by the Chinese CDC, and in early January, the first deaths were reported, and there were cases confirmed outside of China. Right around this time is actually when our practitioners started to come to us and ask us to develop a test for SARS-CoV-2, to detect SARS-CoV-2. And we actually had to say no. And the reason we had to say no was because at that point, the position of the CDC was that SARS-CoV-2 testing should only be developed and offered by public health laboratories, not by private laboratories. So, but there was impending, and obviously over the course of the month in January, we started to really see that this had potential for major global impact. We were sensitive in DLMP to how significant a problem this is and was at that time, because we have a collaboration in China with a collaborative entity called Wuxi Diagnostics, which is a reference laboratory that we have helped develop in China. And so we talk frequently, and they start talking about shutdowns and things that were happening in Wuhan and how difficult this was to contain. So we were really getting quite nervous. So in February, early February is when the COVID-19 disease was actually named, as you can see there. And it was right at that time, actually, that and seeing how this was unfolding and hearing what we were hearing from China, I'll never forget, we had a meeting with myself and Scott Beck and Dr. Binnicker and a few other people where we decided, not without a lot of discussion, but we decided that we were going to develop a test for SARS-CoV-2 on our own, because at that point we recognized that we would need it for the practice. And we also were starting to hear that there were some challenges with the test that was being offered by public health laboratories, just in terms of its performance. So because of those, we committed to developing it. And we actually, at that time, didn't know, though, if we were going to be able to offer the test, because the FDA and the CDC had not changed their position on who could offer the test. In fact, the FDA said it was illegal if anyone performed a test that was not a public health laboratory. So of course, in March, the pandemic was declared, and between that February 11th and March 11th time point, we know how things rapidly accelerated from there. So as I mentioned, kind of our timeline, we in the early January really started to get worried about how big of a problem this was going to be. In February, we began developing our own test. In March 4th, it was when the event that Dr. Karen referred to. So as the president of Mayo Clinic Laboratories, I sit on the board, and actually now chair the board of an association called the American Clinical Laboratory Association, which is actually a trade association for reference laboratories. So I'm on that board. Also on that board are other CEOs, or I should say CEOs of the major diagnostic companies, including Quest and LabCorp. And we have our annual meeting every year in the first week of March. And so I'll never forget, on March 3rd was the actual board meeting. And Steve Ruskowski, the CEO of Quest, and Dave King, at that time the CEO of LabCorp, kept kind of getting up and walking out and leaving the room. And finally they came back in and said, Pence has been calling us since yesterday, and he wants us to come to the White House to meet with him and the COVID task force. Well, then that makes sense. President Trump at that time was very much getting industry engagement around trying to fight the pandemic. But Steve Ruskowski and Dave King and his successor, Adam Schechter, none of them are physicians. So they looked at me and said, well, we don't want to go and talk to the White House task force without a doctor. So Bill, we want you to come with us and participate in this meeting. And there are others. There are others that ended up going, and that was on March 4th. We were out, other physicians, including Sherry Perkins from ARUP and Jerry Husong from Sonic, that went with us out to the White House. And that was on March 4th. And then so came back, and if me showing up at the White House doesn't give you a good sense that you're in for a big, that there's a big problem at hand, you got to wake up. In fact, now I look back on it, and when I left the White House, I was super excited to have gone there, and I was calling my mom and dad and my wife and telling them what the experience was like. Now I look back on it, I probably should have been calling Scott Beck and everyone else and Dr. Frugen saying, hey, buckle up, we're in for a wild ride. And so early March, we set up our testing command center, which I think I'll refer to a little bit more in a couple of slides. And we also established then a little bit later in that month of March, the COVID Innovation Task Force. So here's a picture from that actual meeting. It's with C-SPAN. That's Adam Schechter is immediately to Vice President Pence's right, and then Steve Ruskowski. I was sitting across from those guys, so you just have to trust me. I do have my little placard that I saved with the White House seal on it. And the letter that we got from Vice President Pence I received from Vice President Pence. You can see there, dated March 5th. And it was like I said, it was one of the things that if there is one lesson learned out of COVID to be learned, and that is really the power of the clarity when you have such clarity of purpose. I mean, walking out of that room and on the way in, there was a real call. I mean, we were very nervous going over to that meeting because the day before that meeting was when Trump went on TV and said, anyone who needs a COVID test is going to be able to get a COVID test. And we were all looking at each other and saying, well, what test? Because the only people who were able to have a test at that point were the public health laboratories, and there weren't very many. The capacity was not anything near where it needed to be. So but that clarity of purpose that really rallied together essentially across the industry, from the test manufacturers to the heads of the laboratories, myself included, really was so powerful. And then we were able to bring that back into Mayo Clinic as well. And so how were we able to bring that back into Mayo? Well, what we did was we actually set up a command center, and it was, now looking back, that command center was a room where we all got in and were unmasked, and it was buzzing and humming, 16, 18 hours a day, because we immediately realized that if we were going to stand up testing, that we had to have very high coordination of everything that was needed to set up testing, make it available, testing capacity, testing sites, all of those things. Dr. Karen, of course, instrumental in helping us getting up some of our remote testing sites as well. So we established this command center where we met. We had charts on the wall. All the things that you can see that we tracked there, from what the practice needed to what the lab supplies and swabs to what people needed from Mayo Clinic laboratories, the whole bit. The two things that were really, in terms of lessons, what we learned with this and things that happened, so important events. First of all, in early March, I think it was probably right around March 15th, the decision, or maybe even earlier than that, actually, it was probably more March 10th, that the FDA said that private laboratories could submit tests for EUA, emergency use authorization. We all know what that means now. It was kind of new at the time. So we amazingly, under Dr. Binnicker's leadership, had developed a COVID test. Typically, developing a test takes about 9 months. From that conversation in early February, by March 15th, we were able to submit. Our test was fully developed in a way that we could actually submit documentation to FDA for EUA. The other thing that was really important is that Vice President Pence and President Trump decided that they wanted any of the new testing high throughput instruments to be only delivered to the labs with a national testing footprint, so that they could be used and that capacity could be coordinated through the federal government. So if there's one thing that really illustrated the power of Mayo Clinic laboratories for Mayo Clinic, it's because of that. It was because of Mayo Clinic laboratories that we were able to get access to instruments, the Roche instruments, which were the first ones that got EUA for high throughput. We got those. We got actually 2 of them delivered to us. And that was only because we had Mayo Clinic laboratories, and they were able to promise that we would use those tests and that capacity to help anywhere in the country where testing was needed. And that's why Mayo Clinic laboratories is on there. There were tons of ups and downs. There were the swabs. It turns out the in-house test that we developed in our labs with Dr. Binnicker used equipment that was manufactured in northern Italy. And so, as you recall, northern Italy was a hotspot of COVID early, and shut down their manufacturing. So I remember one of the crazy things is being on with our head of government affairs at the time, Piper Neder-Sue, with the White House, trying to negotiate if they could get a military plane to northern Italy to get back instrumentation to bring it back to Rochester so we could run COVID testing. I mean, that's the kind of stuff that was happening. And then internally, there were so many people coming together. We met every day. We made amazing progress. We were able to get access to the instrument, as I said. I'll never forget one other call was to the CEO of Roche. I had never met him. It was a new guy. I called him, Matt Souse, and he said, well, I got to go because I have to go out to the Rose Lawn to have the press conference with President Trump about the EUA for our machine, but I'll get you what I can. And actually, we now have a very strong collaboration with Roche, which was built through this time. So what were the challenges with testing? Why was it so important, and why was it so difficult? And what are some of the lessons we've learned from it? Well, I have a couple of slides here, which I'll march through, but a lot, especially in the early days of the pandemic, were with just the challenges with measuring the virus itself, how it made people sick, when it made people sick, how it spread, and how we responded to it. And at the time, we were really interested in two aspects in COVID testing. One is shown in the blue line there, and that is when can you detect the virus, right? And that's still a major focus of testing, is what is that timeline between when someone's exposed and then when can you actually first detect the virus to say someone is SARS-CoV-2 positive. And the other is shown in the green and the red lines there, is when can you start to measure an immune response to COVID? Because that was, and I remember bringing that up with Dr. Birx and Vice President Pence in the White House in March of 2020, is that we really should be thinking not just about standing up testing for the virus, but also serologic testing if we were going to understand who is being exposed, and if they had responded and those things. Again, over time, we were starting to realize that this was a very difficult disease to not just to manage, but to detect, right? So it has really two phases. One is when the virus infects the individual and starts to replicate and infect tissues. And then the second is when there's a lot of response, an inflammatory response to that virus, and it can be local to the tissue that it's infecting, or it can be systemic, that causes a lot of problems for patients, and then really can make patients severely ill. And so in that replication phase, people really are not terribly symptomatic. Oftentimes they're asymptomatic, and the symptoms that they have might not always be that of what we would think of as a respiratory virus. So, we think of cough and sore throat and loss of smell now is a big one with COVID. But, we didn't recognize early on that this was, since this was attaching to the ACE2 receptor, which is also expressed in the gut and in the vasculature, that some patients might present with diarrhea, or that some patients might be at risk for thrombosis or clotting. So there was a lot to be learned there. One of the real challenges with this is that, and not keeping people, managing the sick, is that once people become severely ill, they are in the hospital much longer than the typical patient because of all the stuff you're seeing here that goes on with them. And that was one of the reasons why we still do worry about hospital capacity, is because COVID patients, I think the average length of stay is 2 weeks. And so that it's not just the number of people, but their ability to overwhelm the hospitals, because they tend to need a lot of hospital support once they're in the hospital. But what's the challenge with testing? And this is a graph that was shared with me by Dr. Joe Yao, head of our virology lab out at SDSC. And it shows here that basically each dot is the probability that someone with COVID or that's been exposed to SARS-CoV-2 will actually have a positive test by the most sensitive in-lab PCR tests. And as you can see here, so if day 0 is exposure, for those, essentially the first week, you have a higher likelihood, especially in those first 3 to 4 days, you have a higher likelihood of having a negative test than a positive test, even if you have not yet developed symptoms. And this is important. That dotted line, that vertical dotted line, is when individuals typically start to develop symptoms. So what that means is that you have about a 5-day window after exposure where people have SARS-CoV-2 in their system, but they don't yet have COVID. And what was different between this virus and the first SARS virus that caused SARS-1 is that patients in that window can spread the virus. The reason they were able to contain, I want to say we because it had nothing to do with it, but the reason they were able to contain the first SARS outbreak is that patients were most apt to spread the virus, coronavirus, once they were symptomatic. So if patients would show up sick, they could test them for SARS-CoV-1. If they were positive, they could isolate them. In fact, I think they were just isolating people with respiratory tract infections. That's why they were able to limit the spread and not have it get outside of China. This is why it was able to spread and why it continues to be able to spread. Now, the challenge from a testing perspective is, if you think about it, is that means you can't rely on clinical signs and symptoms to say, well, this person needs a test and this doesn't. If this person doesn't. If you're trying to stop the spread of the virus and use testing to stop the spread, that means you have to test anyone who's potentially been exposed. And you might have to test them multiple times if you're in this earlier window when it's more likely to be negative. And this was at a time when we really did not have much, and we didn't really even honestly have enough capacity in the country to manage those who we knew were sick, let alone really do a lot of screening in this setting. this whole need for sensitivity and the need to detect people before they had symptoms to prevent the spread ended up unfortunately being one of the controversial issues around COVID. And are we doing the right testing by the right people? Are we overestimating? Are we overcalling those things? And as you recall, there was a lot of debate around the CT, i.e., the cycle number by which the PCR, how many times you run that PCR cycle to tell if a specimen is positive for SARS-CoV-2. Ended up being a controversial issue. Something I would never have predicted would be something that would be debated openly about a test, because of the need to really be as sensitive as possible. We really wanted to make sure, compared to control, and this is a graph showing our test, one of our tests, and the black dots is the virus, and then in the yellow dot is the control. And it's a little counterintuitive. It goes from right to left, is that as we were diluting, and on the x-axis, and then on the y-axis is the cycle number of times we had to cycle the PCR to be positive. But you can see that even with cases with known virus, that we had to run maybe 35 cycles, which is a lot. So this whole debate and also was unfortunate, but really, because if you recall, there was some that were saying, well, we should only run at 20 cycles and keep it, and that so we don't overcall it. Well, we would have missed, if you see 20 cycles is here at this point, we would have missed, the majority of cases. There was also question about, well, if we have to run it that many times, should we at least be reporting that value? This is a CT value is really only semi-quantitative at best. Should we be reporting the value so that to help understand who's actually at risk of spreading the infection? Dr. Karen did some great work here, and that's shown, and that's essentially that there's only a loose correlation between that CT value and the actual viral load, and not strong enough that we can use it to reliably say who is going to be spreading COVID. And honestly, one of the lessons learned is we still don't know if there's any relevance between viral load and spread and COVID. So if there's one lesson, it's that we have to really study these pathogens intensely as soon as we know that they're circulating in humans, so we can answer key questions about how to use testing to manage patients and then to manage public health. And then just to say, one of the things that Dr. Karen really led was we had tons of companies coming to us and saying, help us, as there was this proliferation of more point of care assays to get increased capacity, help us understand if these work or not. Q was one company Dr. Karen worked with extensively. Mayo has worked with extensively in that regard, but there have been a lot. But as importantly, was really leading to work to understanding what these different tests can and can't do. And again, that's really a lesson learned here, is that if we're going to have policymakers looking at tests to manage public health and to manage society, we really, as laboratorians, have to stand up and say, what can these tests be used for? What are the use cases and what are not? I don't know if we've really truly penetrated that, just because look how often we're using rapid antigen tests, even here at Mayo. Yet if you look in this very nicely prepared table, it doesn't have great sensitivity in asymptomatic patients, and maybe 60–70% at best. So a negative antigen test it's a indicator that you probably don't have COVID if you're asymptomatic, but it certainly isn't perfect. Also is to really understand, and this is still difficult for people outside the laboratory, and the reason why those of us in the laboratory have to really stand up and help explain things to people, both in healthcare and in outside of healthcare, is just the simple fact that the way that these tests perform is very much predicated, particularly if you're using it for screening, right, for COVID, predicated on how much COVID there actually is at the time. So in fact, that was, as Dr. Karen mentioned, one of the things I got involved with was working with the World Economic Forum as an industry, advising all the diagnostic companies and chairing a group of all the diagnostic companies about how do we get all these different sorts of tests out into low and middle income countries, so that we can manage COVID globally. And one of the things and there was work done by the Imperial College to inform that. And actually, you can hit a point where if COVID is so prevalent, you almost don't need a test, because if the prevalence is so high, essentially almost anyone with a respiratory illness probably has COVID. And if you think back to like the summer and spring of 2020, when there was essentially no influenza circulating, that was probably the case. But what's important here is that, again, it focus on antigen tests, which we're still seeing. If the prevalence is low, you're actually more likely to have a false positive test. And you have to think about what that means. So if we're in low prevalence now, and they say, well, because we don't have to mask on airlines, but we want you to take an antigen test instead, well, there's a good chance that you could have a false positive test that would prevent you from getting on that airplane. Conversely, if it starts to go back up, the antigen tests, the number of false positives for an antigen test goes down, but then the number of false negatives, because it does have sensitivity issues, goes up. And so really the real challenges throughout the pandemic is experts like Dr. Karen actually participating in conversations within Mayo Clinic to help our own practice understand how to use these tests to manage our patients and manage risk for providers and patients, as well as on the national and international stage as people talk about using these tests for getting back to society. And this was a lot of work in 2021 in particular, when you had industries like the cruise industry and the airline industry and the hotel industry, and I'm in a hotel today, which were really being crippled by the pandemic and wanted to use testing to start to reopen their businesses. These sorts of conversations were really important. The innovation lab I mentioned, we actually developed 19 new tests in the first year of COVID to help manage patients both with the disease and detect those that didn't have it. One of the things that we did work on with serologic testing was dry blood spots. So because this whole thing of patients that we didn't want patients necessarily coming in and to the hospital, and so if they didn't need to be here, or if they and so we're trying to do as much as possible to do at-home testing, and that continues. And one was the use of dry blood spots, so a finger prick and put it on a card, put it in the mail, so we could do serologic testing for COVID. And we were able to actually show that this worked. One of the challenges, though, and that's shown here, is you can see a positive and the negatives. Positive was very positive, and the negatives were quite negative. So it certainly can work, but serologic testing was one. Again, I championed it at the White House on March 4th. We built a lot of capacity, worked with Dr. Thiel, who runs our serology lab, to set out a lot of serology testing capacity. At one point, again, one of those crazy COVID moments, I was talking with the White House, I'll never forget, on a call with the Secretary of Health and Human Services about setting up a national testing center here where we would fly in specimens from all over the country so we could have a single lab doing all the testing. Because the thought was there was going to be, as the virus spread, we'd see lots and lots of serologic testing to try and understand who had been exposed and if they were protected, because they had antibodies. That never actually materialized. We never really saw it. It's still, serologic testing is at best 1/10 of the volumes that we have seen for actual, viral testing, either antigen or PCR or other methods. And the reasons why that occurred, I think, are really important for all of us to bear in mind, because it says a lot about testing and how we use testing, and how doctors use testing, and how individuals and patients view testing. So probably from a provider perspective, the reality is there was never great clarity in how to use the results. Even amongst different infectious disease societies, there was some that there was a lot of debate about how much serologic testing could be used to say, even if someone had been exposed, because we started seeing there were some patients that maybe had not been terribly ill that didn't have much of a serologic response. So how helpful was it going to be if you had antibodies? It really mean that someone was protected from getting COVID. We couldn't say that. But really, providers didn't know how to use it. The other is that there was, if you recall, in the spring, and we actually did a story with ABC News, I think it was probably in late spring, early summer of 2020, about all of the lateral flow assays, the finger prick blood tests that could be self-administered, that could, you could look for the line if you had a positive serology. Those flooded the market, if you recall, because the FDA decided those did not need to be submitted for EUA. So there were a lot of them that appeared because individuals are really wondering if they had COVID. A lot of those, unfortunately, a significant number had really poor quality. In fact, in that ABC, if you're interested, you can probably Google and find it, the ABC news story. Dr. Gris in Arizona showed that one of the tests that he had, and he just bought them and did sort of a bake-off, actually gave a positive result with tap water. So that really undermined people's confidence, and not just in those tests, but honestly in all COVID tests. So I remember doing a press conference with Governor Walz, because one of the things that we did, of course, was work with the state of Minnesota to set up testing capacity, and Governor Walz wanted to have a press conference after we had accomplished this with the University of Minnesota. And that the first question was, well, what are you doing? You know, are these those poor quality tests that we've been reading about? And of course, they're not, but that really shows how it undermined public confidence. And then the other thing was that we really thought we could use this to measure people's response to vaccination. And as you've seen, the most important thing about vaccination is getting people vaccinated. So the immune response and measuring the immune response really was not important for that. And so this never came together. We now have tests for T cells that we've worked on. And the question is, will they suffer a similar fate? The challenge is that we're not learning. And that's, again, from a lessons learned perspective, it's that if we had done much more serologic testing throughout and T cell testing throughout, we would be able to answer many of the questions that prevent people from using them. But we've never really figured out how to get this supported from a public health perspective. Actually, and I was just on a letter that was written to the FDA, submitted to the FDA yesterday by multiple labs and multiple investigators, saying that we need to do a better job studying this if we're going to understand vaccines and how they're working. So going back to sort of one of the titles of the talk is just what you know, we actually learned from the pandemic, right? And what is it highlighted about healthcare? What have we learned about ourselves? And this was actually, again, I worked on some of this with Matt Souse and Severin Schwan, the CEO of Roche Diagnostics North America and Roche overall, respectively. And one of the things that we learned, and again, we were working with industry, and I was on the call. The other group I was on the phone with a lot was the leadership of Thermo Fisher. You know, so the two largest global suppliers of high throughput COVID testing, along with Serologic, who I also got a chance to meet. But basically, we did not have anywhere near the required global testing capacity for COVID. In fact, I remember, so we were, of course, from Minnesota, the moonshot was to have 20,000 tests a day available to patients, to individuals in Minnesota. We were able to meet that with the University of Minnesota and actually exceed that. I think at some point we were running thousands. I don't want to misquote, but we were running well over half that number here just in the Rochester campus. One of the calls I was on for part of the global health with the World Economic Forum, you know, the country in Africa that had the most testing capacity for high throughput was South Africa. For the whole country of South Africa, they had a capacity of 30,000 tests a day. And that was the most on the whole continent of Africa. So it just showed that we have woefully underinvested in our diagnostic infrastructure, not just in the US, but globally. The other thing, unfortunately, that we learned is that, we need access. The good thing that we learned and really was demonstrated that access to testing, for all the reasons I just highlighted, so important for optimal healthcare delivery. But what we saw with that was that, honestly, we did not, if the infrastructure was underinvested in diagnostics, it was disproportionately underinvested in low and middle income settings in this country and across the globe. The other thing that, and so we need to address that. If we're going to be serious about health equity, we have to really understand, not just for COVID, but for individuals living in those areas, how do we get access? If testing is the eyes and ears for healthcare and for an individual's health, how do we get testing into those areas? The other things that we learned is that we need a modernized regulatory framework, and that's going to come right back around. I have a call here right after this to talk about with other industry leaders about potential regulation of laboratory developed tests. We need a modernized framework that is much more agile, hopefully uses more real world evidence to understand how tests are working as opposed to a lot of very expensive and time consuming FDA submissions, those sorts of things. And last but not least is the power of us as a laboratory and many laboratories working much more closely with those manufacturers of our tests. In terms of just stepping back and thinking about equity and what the role that testing plays in health equity, it's interesting that this is actually something that the person that's individual that's considered sort of the father of modern pathology, Dr. Virchow, Professor Virchow, actually wrote about in 1848 when he was called by at that point the country of Prussia to help manage a typhus outbreak amongst poor coal workers in a part of that country, Upper Silesia. he became very passionate about equity and health equity when they came to the conclusion that a lot of their illness was caused by the fact that they just were living in very poor conditions in a high-risk profession, and that if that was not addressed, that really we couldn't manage effectively the health of people. That came to roost, certainly. I didn't know that going into the pandemic, but we certainly learned it. One of the things that I remember with great clarity was sitting in my office at SDSC at probably about 11 o'clock at night in the very early days of the pandemic in March, and getting an email from someone from one of the Native American tribes in Minnesota with a plea, to get testing out to that community because they had so much communal living. They had many people with chronic conditions that we knew already were at high risk for severe COVID. We started right away. Scott Beck, John Haywood, a lot of people at Mayo Clinic Laboratories worked diligently to try and get testing to those communities. We have something now, but it took a long time. And it just showed that the difficulties between the desire to get testing down to people and the ability to do it with electronics and all those things, very, very difficult, and something that needs a real long view, not a short view. I had already mentioned some of the things I've learned how this has played out. We've learned how this is playing on global health as well. And there's real data to back this up. And I've written even a blog post about this for the ASU blog. But if you look at the zip code, and by zip code in major urban centers, I think they did this, and I know it did in Boston, I think they did it in New York as well. But if you look by zip code, you can see the density or the density or the availability of testing by zip code, and it's inversely proportionate to mean income. So the lower the mean income, the more difficult it was to get testing, which of course, as shown in the next bullet here, is really unfortunate because those individuals living in those communities were much more likely to get COVID and were known to have worse outcomes. So in the areas that we knew were at greatest risk for bad COVID, we had the least access to testing. It's a complex problem in terms of health equity, but solving it's not going to be easy. But I think this has really illustrated that testing and access to testing is going to be really a key feature if we're going to really be serious about helping all Americans manage their health and avoid illness to the greatest extent possible and to the fairest extent possible. So, and then in terms of how do we look forward to and look ahead? I think there's going to be a sustained interest to have more testing occurring outside of the traditional centers, whether it's in pharmacies or at a person's home. I think there is really three things. Number one, it's the convenience, that people will be able to get more information by not having to go into a doctor's office. I think it will be key for the very thing we just discussed about improved access. There's a major effort globally to raise investment to build testing manufacturing capacity in low and middle income countries that is more of the at-home antigen testing and other things, just because, some testing is certainly a lot better than no testing. And last but not least, it'll be, that as we've seen with Mayo Clinic Health at Home, there's going to be more and more of a push to virtual care now, particularly accelerated with COVID. And that means that testing will need to move with it into the outside the hospital setting. I think we're going to see it really. One of the things that we want to understand, and we still need to learn even with COVID, is how access to COVID testing, how access to testing in general can really improve healthcare outcomes, right? And thinking about, again, going back into those low middle income communities, why do they have high risk COVID? Because they have higher comorbidities. So how can we understand getting access to testing for metabolic disease, for common diseases out into those communities, and even into people's home? When you look now, there's a lot of people that are interested, as people are starting to come back into work, about how could our home testing be used to decrease downtime for employees, to stop the spread of illness at the workplace, for instance. And then there really is one thing we really learned is that there's the ability to generate the information, but then how do we actually understand it? How do we, if testing is happening outside of the hospital setting, how do we still get access to that information so we can make the best decisions for individuals as well as the best decision for public health? And that was one thing we talked a lot about, both in the US level, national level, and on the global health level, about how can we get all this, if we're going to really increase COVID testing, how is all this information going to come back in so we understand where there are outbreaks and where we need to get therapeutics? And you've probably read about the test and treat program that President Biden wanted as part of his COVID next phase of the COVID response. We have not, that is something that still really needs to happen. And there was just a quote by Scott Gottlieb, Dr. Gottlieb, former FDA commissioner, saying that now with antigen tests, probably the numbers that we're seeing for COVID are woefully underestimated, because probably about for every one in-lab positive test, there probably are 5 or more that are happening outside of the lab that we just don't know about because they're not being reported and they're not part of some kind of digital system. Thank you very much.
Thank you for participating. Please click the button below to complete the evaluation and obtain credit.